Pet for sponsoring this presentation. As we'll talk about today, some of our focus is going to be on continuous glucose monitors, of course. How many of you are using CGMs in your diabetics? Awesome. So we have quite a few and quite a few of you that are still yet to use. So we're going to do some introductory foundational tips about CGMs today, but kind of get a little deeper in the weeds as to why we should be using this, and certainly what the benefits are for CGMs and some tips and tricks about using them. But also another part of our Fetch series this year is that we are storytellers. So the faculty, we're giving out either mentor guidance or quotes that are great to us or books that we like. And so for those of you that were in my earlier lectures, forgive me for the repetitiveness, but for those of you that aren't, one of my favorite books I would recommend for you is The Comfort Crisis by Michael Easter. Anybody read this book yet? Not yet? One, okay, awesome. Michael Easter has a theory, which I tend to agree with, that humankind, we've gotten very comfortable in life, and we've made everything very easy, which has somewhat stifled our personal growth. And so this book is about when he went on something called a misogi. It's a Japanese term for sort of a self-exploration trip. So he went into the Alaskan wilderness for many months with a friend and learned how to survive. Now, I didn't do that, but I did do something similar when I went on a trip last year and climbed Mount Kilimanjaro. And yes, I actually did that. I know a lot of people are like, oh. Somehow I actually did that, trading downtown Chicago. It was really life-changing, very difficult, but absolutely wonderful. And there is a veterinary trip that does that. So if you have any interest in doing some self-exploration on the side of a mountain, let me know, and I'd be happy to talk about that with you. All right, so let's get into this. First of all, does anybody love Samoyeds like I do? Oh my God, this face. So for us in practice, first of all, veterinarians in the room? Okay, veterinary technicians, practice managers, assistants, very awesome. Okay, so we've got a wide range. So for us in practice, if I say the term diabetes mellitus, which species comes to mind to you? Cats, right? And I love cats, don't get me wrong. We're gonna talk all cats tomorrow. But for tonight, I think canine diabetes is not something that's typically at the forefront of our minds because we just don't see it as much. And it may not be even a topic of conversation that comes up frequently unless you're seeing a high-risk breed, which, did you know, Samoyeds are a high-risk breed for canine diabetes. So certainly a conversation that needs to be in your purebred puppy visits if you're seeing this breed, that they have a significantly higher risk of developing this disease than others. But for the cases where we are talking about canine diabetes, for those pet parents who are gonna authorize wellness screenings, blood work, or, of course, for those patients that are presenting with our classic 4 signs, which are, again, polydipsia, polyuria, polyphagia, and associated, I see you saying it with me, I love it, weight loss, right? Those are the 4 cardinal signs of diabetes that we're looking for. The diagnosis of canine diabetes, I think for most of us, is pretty straightforward, right? In most cases. We'll talk about the diagnostics in a minute, but it's certainly not as challenging as some of our other cases, and certainly not as challenging as oftentimes as diagnosing our feline diabetics. But while the diagnosis for us is typically fairly straightforward, I think we can all agree that delivering a diagnosis of diabetes mellitus to a family that's unsuspecting is pretty heavy. It might even drum up conversations, and we'll go into the stats of this in a little bit, around quality of life conversations, financial limitations of care, or both. And unlike most of our feline patients, where we know over 50% of them can go into an insulin remission in 8 weeks from our newly diagnosed uncomplicated diabetics, in the canine space, diabetes is like herpes. It's forever, right? It's the truth, right? It's a matter of fact. Canine diabetes, once they are diagnosed diabetic, we are always managing that disease. And it's compounded by the fact that many of our dogs also have endocrine comorbidities, right? Like hypothyroidism or Cushing's disease. So it's lifelong monitoring, it's lifelong treatment. So our goals really tonight are to strengthen your foundation in this disease, and we're going to dig into the details of continuous glucose monitoring. I'm going to refer to those tonight as CGMs if you're not familiar with that. And for us to have more effective therapeutic goals. And then at the end, because I also do a lot in the startup and innovation space, I really want to tease some of the technology that's coming our way. It's all already in the human space, but that we have on the horizon. So hopefully you'll get a little excited that we won't necessarily have to be just measuring blood sugars forever. There's a better way for us to scan this. So let's kind of get down to the nitty-gritty of the facts here. Diabetes mellitus, in most studies, affects 0.4 to 1.2% of the canine population. That doesn't seem like a lot, but when you think there's 70 million dogs in the US, it's significant. Its incidence is rising though because of factors like obesity. Now when we think about obesity, of course, we think more type 2 diabetics like felines. But remember, we're learning much more about obesity and certainly the cytokines that are produced during that syndrome, which cause insulin resistance. We also know genetics in certain breeds, and we'll just say poor breeding or irresponsible breeding, pancreatitis, and some of the hormone disorders I've already mentioned. Now, most canine cases, again, resemble type 1 diabetics. Just for pure analogy, remember in humans, that's the juvenile diabetic. So typically our children or some of our younger adults, where they are insulin dependent forever. This is an absolute insulin deficiency. It's either immune mediated or because of idiopathic beta cell destruction. And so that's what we see in our canine patients. Unfortunately, advances in canine diabetes have been pretty gradual. Most of the time, as we look around practices around the country, it's done by either intermittent glucose readings or hopefully what you will leave with tonight is getting away from the dreaded drop-off glucose curve. I know. Just because this is a non-judgment zone, right? Let's just be honest, because I did this for 25 years. How many of you are still doing in-hospital blood glucose curves where you're checking blood sugar every hour? Yeah, a lot of us, it's tedious. It's hard, right? It's maybe not the best choice for a patient that becomes reactive. It's not always accurate. So there's a lot of reasons for us to consider, could there be a different option? Could it be something easier, more accurate, a little bit more emotionally friendly? So those are the digital tools that we're going to talk about. It's going to help us enhance our diagnostic accuracy, refine our treatment plans, and also encourage more client compliance and satisfaction. All right. Why are we not advancing? Okay, I'm going to just use this. So let's start at the beginning and just refresh quickly. Why do our canine patients become diabetics? So there is some baseline pathophysiology to review, but I wanted to also share, because we're trying to be as up-to-date as possible always, some interesting research that's going to help identify some targets ahead, which might lead to us having some earlier detection or more proactive interventional treatment. So the basic physiology of diabetes mellitus, remember, remains rooted in an insulin deficiency, an absolute insulin deficiency, meaning there's just not enough being produced. But emerging studies have suggested that it's much more complex than that there is an immune-mediated component, of course, genetic and even environmental conditions that contribute to this. So it's become much more multifactorial. So there's a lot of research being done into autoimmune markers, and that's showing a lot of parallels between canine diabetics and our type 1 human diabetics, most of which is looking for lymphocytic infiltration of the islets and Langerhans, and then the presence of islet cell antibodies, which we weren't looking for before. We're now seeing those in very high prevalence in Samoyeds and Cairn Terriers, so 2 of the highest risk breeds for diabetes in dogs, and starting to look for it in other breeds. So again, islet cell antibodies is in the future is looking as a potential biomarker for this. And as I mentioned biomarkers, of course, we are very familiar with some of the more common recent biomarkers that have changed vet med, SDMA being one of them, of course. So looking into insulin resistance mechanisms, especially in our obese dogs, which of course we never see obese dogs ever, and those with the concurrent endocrine diseases like Cushing's disease and hypothyroidism are really expanding how we look and understand this disease. This paper, if you're interested in reading, really looked into the inflammatory cytokines. I kind of teased that before talking about obesity, but we know in humans and in our canine and also feline patients that when a patient is obese, remember fat cells are incredibly active cells. They produce a lot of cytokines. We know here IL-6 and TNF-alpha in particular that are implicated in the development of peripheral insulin resistance. And that is, of course, one of the key risk factors for us developing this deficiency. So as we think about this, again, we're going to start looking into some of our high-risk breeds, but I want us to kind of keep in mind that as we look to the future of this disease, earlier detection before these patients even become clinical, so a subclinical biomarker would be ideal, and that's where this research is going. Genetic studies have also, as I alluded to, have highlighted some breed predispositions. So there was a very recent 2022 study in canine genetics and epidemiology looking at some different gene loci associated with diabetes susceptibility in different breeds. High also risk, schnauzers are no surprise, of course, they're kind of the poster children, but also Australian Terriers are paving the way for some of the genetic screening protocols. And here's more of our susceptible dog breeds. So these would include poodles, Labrador retrievers. Don't forget, I think we often think the canine diabetics are our small and toy breed dogs. Don't forget we have some giant and large breed dogs that are predisposed. Labrador retrievers, our dachshunds, our beagles, Samoyeds, case hounds, miniature schnauzers, Bichons, Yorkies, there's a lot of them there. Why do we need to know about susceptible risks for breeds? Twofold. One is, as these dogs are coming into us as puppies, we don't put on the scare tactics in our first puppy visit, but we do need to tell them that there is a higher risk in this breed of this disease ahead. As an 8-week-old puppy, are we worried that they're going to be diabetic at 6 months old? No. But we have to keep planting the seed. And the reason is, the second reason that kind of ties into this, is one of the few good things that came out of COVID is a massive pet adoption. What we found though is that most of these pet adoptions happen to first-time pet parents. So they are completely unaware, many of them, that dogs even get diabetes, let alone that they've adopted a high-risk breed, let alone that these are type 1. Because many adults that have developed diabetes, if they're trying to kind of anthropomorphize to themselves and their dog, most of them are on metformin. Many of them are taking non-insulin strategies for diabetes. They don't recognize that canine diabetics are insulin dependent, at least right now, indefinitely. It's a different disease. So it's important for us to plant the seed early. Doesn't mean their dog's gonna get it, but it's certainly getting them aware of what to be looking for, why wellness screening is so important, why it's very important for us to be looking for clinical signs early at home. Now the physical exam. I'm certainly not going to bore us with how to do a physical exam. We all know how to do those. What I want to point out, though, are a couple things not to forget during your physical exam. So the first thing I want to point out is that these dogs often are diagnosed by surprise. How many of you have diagnosed a diabetic dog on wellness visit when no clinical signs at home? Some of you, yeah. It happens, and it's happened to me many times. Why is that? Because these dogs are eating. Most of the time, we have dogs that come into us on an illness exam because they're not eating well. But eating, to many pet parents, is a sign of wellness. So these dogs are ravenous. They can't get enough food, but they're losing weight. Remember, I'll reinforce the 4 cardinal signs of a diabetic: polyuric, polydipsic, polyphagic, but losing weight. Almost every diabetic will have some semblance of those 4, maybe just in different levels of intensity or changing depending on the disease course. So these owners will frequently report a very good or even really awesome appetite, yet they're losing weight because they have a catabolic state. They're burning fat, they're burning muscle for energy because they have inadequate insulin. Remember, as kind of layman as I can make it, right, with diabetics, insulin is the key that opens the cell to allow sugar to go in for a cell to use energy. If there's not enough insulin to open the cell, or there's resistance. There's something blocking the lock and the key doesn't work. Or the lock's different now and the key's wrong. If that cell can't open up and take glucose in, it's got to use other energy, and that's where we get ketotic, and that's where we start burning fat and muscle. So what we're looking for is that epaxial atrophy. We see that a lot in cats, right? Where they'll feel a spinous process and they have a big belly at the bottom. What we're looking for is a dog that is losing appropriate muscle. Often down the spinous processes, can be generalized often, but that's the first place we want to look. Or we're starting to see suborbital sinking, right? The fat pads behind the eyes are starting to sink in. So if we're seeing that, and of course we're trending weight, that's concerning. Remember, these dogs are polyuric and polydipsic. That excessive fluid loss in the urine is going to lead to moderate hydration. We can see evidence of that on physical exam with our skin tenting, attacking mucous membranes, elevated capillary refill time, and certainly we can see that evidence biochemically on our labs. Here's the other things to remember though. Bilateral, rapidly developing cataracts are highly specific to diabetes, and especially our diabetic dogs. Middle-aged to older, it can happen literally in a matter of weeks. Okay, so this can happen, you saw the dog 2 weeks ago and all of a sudden this dog has cataracts. Lens opacification, right, we'll see that. Certainly everyone here probably is very familiar, or at least fairly comfortable diagnosing a cataract, but often these dogs will come in because they are bumping into things. So an owner might report, hey, I just moved the bed and my dog's bumping into it, what's going on? Obviously these can rapidly turn into blind situations. These are also dogs that need ophthalmic intervention quickly, because those cataracts are a high risk for secondary glaucoma, okay, from uveitis. Often remember, the skin is the first place to show disease and the last place to get nourishment. So these dogs come in with a very poor coat quality typically. Very flaky, they have chronic hyperglycemia, and that leads to altered metabolism of the skin barrier. So it can look very dull, very dry, higher risk of abrasions and wounds, poor wound healing, we'll see that. The final thing that I want you to do is make sure you're abdominally palpating these dogs, because more times than not, you will feel an enlarged liver sticking out from the ribs. Now, I think abdominal palpation is quite subjective. Some of us feel really comfortable with it, some of us it's kind of hit or miss. Just remember, as you're palpating the ribs on a dog, we should never feel anything firm coming out from the edge. That's hepatomegaly. It's quite common in our diabetics. We'll often see changes biochemically to support that. But if you feel that, again, supporting evidence, and it's going to be enlarged and firm on palpation. Here's some subtle things that we might see in our earlier cases or poorly regulated cases. I talked about the muscle wasting, but along with that, we often will see mild weakness, especially in the hind limb. These often, sometimes, will get referred to neurology because people think there is a neuropathy starting, and you are right. It is starting because many of these dogs are going to have a mild neuropathy or gait changes. Now, we classically can point out a feline diabetic neuropathic change from across the way because they're walking on what? Yeah, they have a plantigrade stance. It's not usually that common to see in dogs. In fact, it's a much more subtle finding. But I hope you can appreciate from this dog that it looks like they have some hind limb weakness. We also will see just general lethargy. So these are dogs that, they used to love playing ball. They might play twice and they stop. They used to run up and down the stairs 6 times at the end of the night. They do once, and they kind of lag on the last 2. They're pulling at the end of the walk for those dogs to finish. These are the common things that we'll see. The last one, of course, I'm sure many of you can probably guess, is our UTIs, urinary tract infections. Very, very common for us to be screened for this. We'll talk this more about in our ClinPath. But what I wanted to make sure that we talked about is actually transient ear infections. This is a subtlety that can go along with canine diabetics before we actually see a diabetic arise. So dogs that have this will often show sort of a recurrent, I'm going to call it a sterile inflammatory change. We don't know yet why this is happening, but it's been shown in 2 papers to actually be associated with our canine diabetics more frequently than non-diabetics. So just keep it in mind, right? We're doing a complete physical exam. If you're starting to see a dog that's a Samoyed or a Schnauzer or a Dachshund or a Lab that's getting some of these with no history of allergy, I'd at least be screening blood work to be looking for it and looking for those cardinal signs. Obviously, with our UTIs, glucosuria is a favorable environment for us to develop infection, and in our emergencies, ketotic breath and vomiting would be some of the major things we see. So let's go through our diagnostics a little bit more. We know common blood abnormalities. I'm not going to spend a ton of time going through this, but these would be the classic findings that you would see. Hyperglycemia usually, almost always, is greater than 200 milligrams per deciliter on your chemistry profile. It's diagnostic for diabetes when it's persistent and accompanied on the same sample, right? So we get paired blood and urine always, as long as it's possible and the patient has urine, because we need to see that at the same time, concurrent glucosuria. Just to kind of get off my soapbox for just a second when we're talking about paired samples, especially in cats, please make sure if you're going to do labs, if all possible, we're always getting urine at the same time, even if you save it, even if you just do a dipstick, because it's so critical for the diagnosis of so many other diseases that we have. But in this case, that is considered diagnostic. Now, I mentioned liver. We will often, in our canine diabetics, see elevated ALT, elevated ALK phos, elevated GGT, because these dogs are fatty liver dogs. They get hepatic lipidosis. They often get vacuolar hepatopathy if you're doing any kind of aspirate or biopsy. It's a secondary steroid induction that they'll often get. So we'll see these changes on lab work. We should be screening for cholesterol and triglycerides in these dogs. They're almost always elevated. In fact, if you were in the opto lab, we talked about this a little bit. The hypertriglyceridemia can cause a lipemic uveitis in these dogs. So if they have a very high level of triglycerides, the good news for us is that there is no, at least right now, stringent recommendation on dogs having to be on a specific food for it to make a massive difference in the canine diabetes regulation, except for when they have high triglycerides. These dogs need to go on a low-fat diet. These dogs need to go on something like a Royal Canin GI low fat, or the ID low fat is also quite effective, fish oils, and other strategies. The final thing we look at, of course, is elevated fructosamine. Remember, this is looking at the last 2 to 3 weeks of blood sugar, sort of looking at the mean. Elevated levels are going to confirm that chronic hyperglycemia. So if you were at all worried that it was a stress-induced response, not as common in dogs, of course, as it is in cats, but it's especially helpful in distinguishing between stress-induced hyperglycemia and absolute chronic hyperglycemia. Not so common, what you might see accompanying on that CBC is a stress leukogram. So that's a neutrophilia, monocytosis, lymphopenia, remember that? And then in electrolyte abnormalities, if you're starting to see electrolyte abnormalities, your brain should really be shifting from that non-complicated diabetic to, do I have a DKA that's smoldering? So we will see hyponatremia, hypokalemia, even hypophosphatemia. And these are not ones to just shrug off. We need to address them, certainly with fluid replacements and some of the other strategies for a potential DKA. If we're not at a DKA and this is a diabetic who started to vomit, those clinical signs need to be addressed, because all we will do is perpetuate that cycle into a DKA more quickly. And again, don't forget your liquid gold, aka urine. We see glucosuria, but obviously looking for ketones, and certainly if those ketones are present, we have a different situation on our hands and we're life-threatening. A lot of times in these patients, we will see absolute proteinuria and plus or minus bacteriuria. Now, if you're looking for protein, remember, of course, the only way for us to diagnose true proteinuria is with a negative sediment. So keep that in mind. Early diabetic nephropathy patients will also have a higher risk of UTI. So if you're diagnosing this sort of backwards, if they're coming in for weakness, hind limb weakness, potential neuropathy, Again, don't forget to be screening their urine. Often they're associated with a concurrent urinary tract infection. Now, a couple novel biomarkers that are on their way that are being validated and certainly encouraging and inspired from translation in human medicine is looking at glycated albumin and A1C, or hemoglobin A1C. Are any of you in this room, do you have a family member who's a diabetic, or are you a diabetic or familiar with? Okay, so A1C is a very common measurement in human diabetic management. It's a little bit different, but this was a study that was done. Glycated albumin is a biomarker of short-term glycemia. So this is something that we would hopefully pair sort of in between a spot blood sugar check and a fructosidine. So this would fit kind of in the middle. So this was a pilot study, very pivotal done. It was interesting, looking at 30 dogs that had, so 10 that had diabetes and 20 that were healthy controls. Many of these dogs were on CGMs, which is awesome, so we were able to get a pretty good idea of what they were doing across the board. And looking at the fructosidine and A1C, the glycated albumin was very closely associated with accuracy in our mean glucose levels as we're looking in short term. So this is up to 2 weeks, whereas fructosamine would be more like a 3-week marker for chronic. So this is more in that subtle, again, range. We don't want to spot sugar, but maybe we want to look at how this dog has done over the last week. That would be the target of this biomarker, and that's what we're looking at. So 1 to 2 weeks of glycemic control. This is going to allow us to do a little bit more frequent monitoring if we wanted to. The thing to remember is that what these monitoring tools are going to be are complementary to fructosamine. So depending on how compliant your pet parent is, depending how often they can come back to see you, you're going to have some options to kind of fit the bill if you're looking for more acute look versus 3 weeks or longer. This is also another very cool study that's being done at the Royal Veterinary College I want you to be aware of. There is a technology looking at a different, very specific type of lipase called DGGR lipase. DGGR lipase uncovers subclinical pancreatitis. So it's present, that we know of, it's present in up to 30% of diabetic dogs. Why do we care about subclinical pancreatitis? Well, if we can uncover pancreatitis in these patients before they're clinically ill, not only will it take less for us to intervene because the disease isn't advanced, but as we know, all these immune-mediated disease kind of complex factors that are emerging and being discovered, one of them being pancreatitis, the hope is in the future we might be able to prevent clinical diabetes from arising. So this is also coming. They're still in the midst of this trial at the Royal Veterinary College, but the results are very promising. So hopefully what the goal would be is just like SDMA allowed us to have earlier intervention in what was happening in the kidneys, this would be something, instead of doing a PLI or some kind of spec CPL, we'd be able to utilize this to detect pancreatitis earlier, and especially in our diabetic dogs. Okay, moving on to insulin. I'm gonna just talk a little bit about some of the types of insulin. I am not going to be doing an insulin recommendation tonight because of course we know every patient's a little bit different. We have our own comfort levels with insulin. This is more of just to inform you and have you make your own decisions, and certainly to introduce you to some insulins that you may not have been aware of. Vetsulin, I think pretty common, everybody's fairly familiar with this. It is the FDA approved insulin for dogs. The big thing with Vetsulin, of course, if anyone not familiar with Vetsulin, I don't want to bore you. Okay, just as a quick reminder though, remember these are U40 syringes. And when this was launched, I think this was a big possible mistake that many people were making by drawing this up in a U100 instead of a U40. It's a very different concentration. More recently, I think people are getting much more happy with the Vet Pen, so very similar to what is used in people. The big thing about Vetsulin, please do not forget that this is literally a shake. We're not rolling this insulin. You literally have to shake it into solution for it to be effective. So please make sure that if you are prescribing Vetsulin to your clients, we absolutely have them do it every time before they administer. If they're doing this more traditionally, we don't have to shake the Vet Pen. Okay? I think what is coming more in favor, how many of you are using Levemir in your dogs? Any of you? A couple of you, okay. So if you haven't used Levemir yet, this is a long-acting recombinant human insulin analog. It's gaining a lot of popularity because it's more potent, it lasts longer, and it has a flat profile. So we're not getting curves. We're getting flat road ahead, which is the goal, right? To keep our time in range as long as possible. So some of the advantages of this is that it has very predictable absorption in most dogs. So we don't get a ton of bioavailability variability. It has once to twice daily dosing, which is encouraging for some of our families where maybe compliance isn't the best. But the thing to remember about Levemir or Detamir is the other name for it. It's significantly more potent in dogs than in humans. So I have it on there on red. Please keep this in mind. It's 0.1 unit per kg. It's a much lower dose, and we start low and titrate up. Okay? You're going to be very shocked at how small the amount is being given. And what I would suggest to you is that if you had a patient on Vetselin as an example, and you're switching to Levemir maybe for better regulation, if you haven't already, have them clip an area so they can actually see what they're doing better, because the doses are going to be much smaller, and clients are going to wonder if they're actually getting this in, if they're spraying the skin. But it is a much more potent insulin. So something to consider, especially if you've tried Vetselin and have not had great success, and you've ruled out other courses of resistance. Now people are going to be like, why do you have this up here, Dr. Marks? That's for cats. I know. But there's more work that's kind of experimenting to see if Lantus, or glargine as we know it, right, one of the top insulins that we use in the feline species, could this work for dogs? Remember, this is an alternative long-acting insulin. What internists and some of the experts are seeing is that glargine has the possibility of fitting in dogs where there's overlapping action needed, or there's a Somogyi effect after an intermediate acting insulin. So while this will probably never be a primary insulin for us, there are some dogs that we're using this supplementary to cover some of the overlap. So keep that in mind, that if you see this from an internist, that's why it's being added into the equation. And then finally, this is a newer option. Is anybody using Tresiba or had any of their patients come back from an internist with this? One? You're the Lone Ranger. So this is not, I'm not going to say this is widely adopted across veterinary practices today, because it certainly isn't, but there's a lot of specialists that have started using this, so I want you to be aware of this if you're getting reports back from referrals. So this is being predominantly used right now in refractory cases or difficult to regulate cases, and the benefits of this is ultra long acting. This can last over 42 hours. Okay, so this could totally change the game. Minimal variability in absorption, so it's quite predictable, and the other benefit of this is it has a very low risk of hypoglycemia despite having a duration of up to 42 hours. It's still considered, again, being evaluated, and this is not, I would not say as a GP, run out and start getting this for your patients. It's more for you to be aware that more and more specialists are dabbling in this. And if you have a hard to diagnose or to treat or monitor diabetic or a comorbid canine diabetic that you're sending out to referral and they come back with this is what it is, okay? Ultra long acting, minimal variability, low risk of hypoglycemia. It has a lot of promise for us in the near future for dogs that have very unstable curves or are sensitive to insulin fluctuations. So again, keep this in mind. There's if you want to read more about this, there's a 2025 study, here it is, looking at Tresiba protocols and practical use. This was just in 2025, in January of this year. This is very recent. They looked at 33 dogs. The initial dose that they found they were using in this was about 1/4 unit per kg. Okay, so also very low, once daily. You can imagine, of course, we don't need this if it's lasting up to 42 hours or more. We're not going to be dosing this twice daily. In the continuous glucose monitors that were used in these 33 dogs, they saw the mean glucose on this insulin drop from 333 to 229. So pretty significant. Thank you, John. Everybody have something to drink or eat hopefully. Okay,
We have more if you're looking for more.
There's more, if anybody wants more. Okay, I won't take it personally if you're running out for more food, promise. Okay, so what's ahead? Well, endocrinologists, as we know, and some of our experts in the field are certainly working with these insulins in combination, working more with Tresiba, looking at a long-acting basal insulin like Levemir or Detamir, with something like a rapid-acting insulin like Lispro. So there's a lot in the future, but the key is we don't know how to do this and tailor this without continuous glucose monitoring. So I want to talk a little bit more about this so we can hopefully shift away from what I consider very physically taxing, emotionally stressful, and certainly very tedious in-hospital blood glucose curves. We've all lived that. Believe me, I've lived it. I know many of you have. And I'm certainly not saying if that's your only option to stop it, because we do what we can do. But if you're open to thinking about how technology could ease this for your patients and your team, I want to talk a little bit more about CGMs, or continuous glucose monitors. So what these do, of course, is they measure glycemia in diabetic dogs and cats without the need for blood sampling. So these are detecting glucose in the interstitial space rather than in blood or plasma. That's how they work. The interstitial glucose is in equilibrium with the blood glucose. The thing for us to remember, there's a lag time of about 3 to 7, so about several minutes. It depends on the dog. The exact time species will vary also across species. And the elapses will change in the blood glucose first before they go to interstitial space. Okay? So if you checked your CGM at the exact same time as your blood sugar, and you're like, it's not the same, Dr. Marks, I'm not surprised, right? Because there can be a little bit of a lag time in your CGM. Now, I'm not talking hours, I'm talking several minutes. We're looking more for trends, and we're looking more for time and range, which I'm going to talk about in a minute. So CGMs, the nice thing about this is we can collect data over several days to weeks if we need it. We get on-demand, real-time information. We can get high and low trends. We can get trends over different periods of time. And the nice thing is it allows us to really tailor insulin to what we need. Now historically, right, when we're doing our diabetic monitoring and certainly some of the intensive in-hospital monitoring with serial blood glucose curves and fructosamines, we know that dogs, even though not like cats, they still can get stress-induced hyperglycemia. There can be sampling limitations. We get busy. Tech team can't just sit around all day waiting for that hourly blood sugar. Maybe that patient's getting more reactive as the day goes on, right? We've got lots of potential limitations. If the clients are doing this at home, there's some clients that are amazing and some are getting 1 or 2 readings a day, right? Or they're checking their own blood sugar, which I've had before. I don't know if any of you have had, but there's also inaccuracies. We know that hematocrit can influence certainly our blood sugar readings, capillary sample contamination, the timing and variability of when insulin was given. So there's a lot of reasons that we need to think about getting away from our standard traditional serial blood glucose readings and think about using CGMs. So if you're just starting out in this, I wanted to just refresh a couple of the common areas that we place this. So the most frequent applications are the dorsal aspect of the neck, between the scapula, the lateral thorax, especially in your deep-chested dogs. You can also do over the hip, although that's one of my least favorites because I feel like they have more access to that, but that is possible. Or if it's we'll just say somebody that has some cushion for the cushion, right? A big, huge, obese lab that's got a lot back there, you actually can also do it over the skin of the lumbosacral spine. My preference, though, is between the scapula. It tends to be the place that they have the least amount of access, and it's easy for us to do a surgical sock or some kind of t-shirt or something to keep that a little bit more protected. It's got to be where it can be comfortable for the patient. Most of these CGMs are, but certainly if it's, if this dog is quite sarcopenic and has a very little sub-Q fat, we don't want to be putting it right over bone, not easily dislodge or remove. We want to avoid any place where there's a scar. We won't get as accurate a reading. Again, the places where there's been minimal to no subcutaneous fat, because we're not going to be able to pick up our interstitial glucose as well. And we want to avoid putting it directly over a spot where insulin is always given. So if they're always giving it the same spot between the scapula, have them shift it back a little bit or put it in front of it, cranial to it. But we don't want to go right over where they always give because we know subcutaneously there will be some scarring and fibrous tissue there, okay? To start off, once you identify where you're going to place it, we want to clip a 4x4 square area. We're going to clean the area with an alcohol wipe and then allow it to dry. You know, again, please make sure it does dry. Don't just wipe and go. We do need that area ready and prepared. So once that area is prepared, and I'm giving you a strategy tonight that is for almost, it's pretty unanimous and kind of across the board for all CGMs. There might be some little bit of variability in regards to the adhesive, but this is for all CGMs. Once you get that, you're going to take the sensor pack and peel the lid off and unscrew the cap. The cap is rotated and you're going to remove the bottom cover and you'll take it out and look at it and you'll see the applicator underneath. Then you take the bioadhesive, it's applied around the probe. Typically we do 1 drop at the top, 1 drop at the bottom, and then right and left, so sort of 12, 3, 6, and 9 o'clock. And then we place the applicator down on the shaved area, you'll hear it click. And then we wait about 3 to 5 seconds and pull the sensor applicator away. And then what's left, of course, can just be thrown away. If you want, we're not going to go through a video specifically, but if you visit the Adipet booth downstairs, you can play around with these and actually feel and touch what the CGMs look like a little bit more vividly. So the thing is that if you've been using CGMs up till now, Freestyle Libre, of course, would be the most common one that we use. Remember that that is calibrated and validated for humans. And we, you know, veterinarians, we are masters, right, at creative thinking, and certainly Freestyle Libre, it's off-label use, we don't care, right? We're gonna be utilizing strategies that help us, often human-translated devices or therapies. The cool news about the Adipet CGM is it was designed and validated specifically for dogs. So we now have a new version that allows us to say, hey, if we really want to look at this and look at the validation, we know that this was designed for the species in mind. So think about that. There was a study done in 2020 that was looking at validations of these CGMs. So if we look at something called the MARD, so this is the mean absolute relative difference. So this is looking at the average difference in range of glucose readings of a CGM compared to the accuracy of an actual blood sample, right? So how closely did the CGM represent what the blood sugar actually was, of course, keeping in mind that lag time. So for the Freestyle Libre, it was 16.4% change, which is not horrible, it's actually quite good. But now with Adipet, we're improving it to 13% and dropping every single version, okay? So we're improving our accuracy and validity of this as we start to validate something and make it directly for the canine species. This is an example of a dashboard that you might see with a CGM. There's a lot going on here, right? You might be like, oh, it's way too much data. So while you can dig into the details with these patients, what I really want to talk to you about is something called TIR, or time in range. This is talked about all the time in human endocrinology. We rarely talk about it in canine and feline endocrinology, but specifically for us today, I want to point out to you, this is the key range that you want to be looking at on your dashboard besides hypoglycemia and hyperglycemia. You're looking to see how long, and that is your challenge, how long can I keep this dog in its TIR, meaning it has a healthy blood sugar, what percentage of the day and night. It's sitting in the appropriate range, how long throughout the day. So if you have a dog that time in range is 26%, awful, right? That means that 74% of the day, that sugar's too high or too low. Not great for regulation. So the higher our TIR, the better our regulation, okay? It's an easy way for us to kind of take this dashboard and take a look quickly and say, hey, we've got, in this case, I think this patient coming up here is pretty high, right? Can't see that well, but I think the target is pretty high. But if we look at this, just one thing to think about the time and range, remember that for a canine diabetic, our time in range is 100 to 250, 24 hours a day. That's our ultimate goal, is we want them to stick between 100 and 250 milligrams per deciliter throughout the day. So as we think about that, that is, again, that's our holy grail of canine diabetes management, and that's crucial for them to have the longest life without those necessarily complications and certainly difficulty and challenges in insulin regulation. So again, this is what human monitoring looks like. We're looking at the time in range, we're looking at our average sugar, we're looking for periods of hypoglycemia, we're looking for periods of hyperglycemia, we're looking for when that happened during the day, we're looking at this in relationship to when the insulin was given. Why is this so critical? Because for us to start tailoring insulin the way it needs to be done, for us to start working towards those longer 42-hour acting, long-acting, ultra-long-acting insulins, we need to see how long it lasts, right? The good news is some of these newer insulins have much less variability per dog. It's not like it lasts 24 hours in this dog and 38 in this dog. We're seeing more predictability, but we need to be able to see what it's doing so that we can vary it accordingly. So this is what happens in human medicine. Just to give you an example, a 70% or higher is the ultimate goal for TIR in humans. Okay? Now I'm super competitive. So for me, I'm gonna look for like 95% with us. But in human medicines, what's considered a great control of a human diabetic is a TIR of 70% or higher. So just keep that in mind for your patients. So what else are we looking for in these dogs? So let's say your TIR is crappy, right? Let's say it's 36%. And you're like, I feel like the patient's getting the insulin, the client's compliant, we've tried increasing the dose, this dog's not getting any better. What am I looking for where there's insulin resistance? Well, we start looking for, especially with the CGM, which is really helpful to be able to show a lot of variability when they used to be regulated. We're looking for UTIs, we're looking for pancreatitis, we're looking to see if suddenly, and this is a big one, please don't miss this, did that pet parent suddenly start using a steroid and didn't tell you? It's allergy season, and they somehow borrowed a steroid spray from their neighbor, right? Or it was left over from 4 years ago sitting on their shelf. Or, my favorite, my dog has an ear infection, can I use the Otamax or Animax from 1982? Is it still good, right? They didn't tell you, and they're using steroids. Doesn't matter if it's topical or oral, it still will affect a diabetic. And obviously all of those, bless you, will start to cause insulin resistance. So as you see and use the CGMs to look at glycemic variability, those are the questions to be asking. Now, we might love these CGMs, do pet parents. So they did a study in 2023, ACDIM looked at this. 82% of veterinary endocrinologists and internists were using these in their cases, at least 25% of their cases, and steadily increasing. And ask these owners, what do you think? Is this too much to manage? Is it weird to have this thing attached to your dog for 9 to 14 days? What do you feel? Would you rather be checking blood sugars? Would you rather be checking nothing at all? 87% of owners in that study said that the CGM made them feel more confident, more connected, made them trust their veterinarian more, and 72% of them were willing to pay for repeat CGMs every 3 months. So it's really encouraging when we think about diabetes, especially those pet parents that are just, they have the blank stare when we give them the diagnosis and they're like, how am I going to do this? This is a wonderful option that we know in majority of pet parents is very successful and satisfactory. Now what can happen obviously with CGMs? Certainly there can be complications, and when I say complications, I'm not talking medical, talking more device, right? So most CGMs are designed to last 14 days, okay, give or take a few. But studies have shown maximum sensor life was reached in about 70% of dogs, 60% of cats. So why is that happening? Well, some of these patients can get mild erythema at the site. Some of those patients dislodge it for us, of course. Sometimes the tissue adhesive can loosen up. especially if you are a conservative adhesive applier and you're just doing a couple drops, please make sure they get at least the 4. And if the sensor detaches prematurely, the nice thing about a CGM is you'll know pretty quickly because you'll stop getting any readings. So rather than letting that patient just kind of get lost in the shuffle, we can contact them right away and see what happened. The other thing that I think people get questions about with CGMs twofold is, one, is that pet parent going to sit there on their app all day long looking at the data? And more importantly, am I going to get called morning, noon, night, overnight, and get emails and texts every single time they get a reading? So I think it's important for us as a profession to think about we can have boundaries with this and give them support so that CGMs are effective for us. So it's important, certainly, if there's ever an emergency, we tell them to call the clinic, call ER after hours, that they have guidelines that they are not modifying insulin dosages on their own. We don't have them look at the CGM and go, oh, it's a 312. I think I'm going to give a half a unit right now. There are clients that might want to do that. We set boundaries with them and tell them that mild fluctuations in blood sugar, of course, can be normal. So this is a little bit of a learning curve, and I certainly, with colleagues and KOLs that I work with, it's something where we talk about there might be some clients where you might have to have a pretty difficult rule conversation about CGMs. And maybe there's some clients that we don't start with CGMs because they may not be able to follow some of these rules. But for the majority of our clients, this dramatically elevates their ease and satisfaction in monitoring their patients at home and also feeling much more confident with our relationships. Now, I say this all in the lens of a perfect world, right? Fully compliant client, no financial burdens, no other constraints. They're the ones that are saying, thank you so much, right? They're the clients that we go home and we're like, this is the best profession ever. There's a lot of clients that we have that same sentiment. They have hearts of gold. They want to do the absolute best for their dogs. They get a diagnosis of diabetes and they are crushed inside, not because they wouldn't do it, but because they are financially limited. And we see that now, and we're going to see more of it. We have a changing economy, we have inflation, we have a risk of recession, and most importantly, there's rising costs of veterinary care without a ton of payment solutions, right? So although diabetes mellitus in dogs is very treatable, the euthanasia rates are high, 10 to 40% at the time of diagnosis in one study. Another 10% within a year of diagnosis. Sucks. It's hard to see these stats, especially when we know, again, that most of the time we can improve these dogs' life. A survey of 224 US dog owners in just the last 2 years found that 64% of them, so 2/3 of these dog owners, found that the treatment for diabetes was too expensive and it was too hard to manage. So we're left going, what do we do? So the beauty of this is that spectrum of care has become top of mind. It's being discussed. And there was an awesome editorial just recently in the July JAVMA, so in July 2025, looking at spectrum of care in diabetes management. And I would encourage all of you, whether you're a firm believer in spectrum of care or you're like, spectrum, I don't care about that. Whatever your feeling is, I think it's an important article and editorial for you to read and think about some options that we can provide these clients so that euthanasia is not where they go first. Or at least we give them informed options to make a good decision. So what is this? It means thinking about a tiered approach. Minimal diagnostics, basic insulin, thinking about a CGM in a limited way. I'm going to give you a way to think about that for affordability in a second. Another option, and please think about this with your canine diabetics, is that there is no universal diet recommendation for canine diabetes. By any expert, by any consensus statement, there is none. So if you have a client who's like, I'm really struggling here on this financial burden, and they're on a therapeutic diet, take them off the therapeutic diet and use some of that money towards treatment. We don't need to do that. Now, there are some flip sides to that hypertriglyceridemia client, right? Where we're worried about lipemic uveitis and certainly that. If obesity is part of the problem, of course, working on that. But the underweight dogs need a calorie-dense diet. Overweight dogs obviously need to lose weight. If there is a comorbidity, if they have chronic kidney disease, certainly we have to think about prescriptive. But for your standard non-complicated diabetic diet, we can save money on the prescriptive therapeutic diet and think about putting that towards therapeutic treatments. Veterinary rechecks. We all want to see these dogs back and very frequently, but not every client can do that. So when we have patients that have poor glycemic control within 3 months of diagnosis, we know that's linked to shorter survival. Let me say that again. If you diagnose a canine diabetic and you are struggling in the first 3 months to get control, it is on us to tell that client these patients are going to have shorter survival times. They need to know it. They just need to know it. Doesn't mean they will, but they have a much higher risk. So to balance our costs in care and provide veterinary support, think about telehealth, think about those owners doing weights at home, using CGMs if they can, doing as much from a home diagnostic perspective, and we try to, again, accommodate that through telehealth appointments so we don't have to do all the diagnostics in-house. Now, can we use a CGM to really improve spectrum of care? Keep in mind that a lot of our practices are thinking about doing rental programs. Could you do this at your practice, right? Cost is our biggest barrier. Just to keep in mind, a Freestyle Libre sensor, depending on where they're getting it, usually costs $60 to $100, okay? So just to kind of keep that in mind. This is going to be something that we talk about. The full kit with the reader can be in excess of $150. Now to me, any of these CGMs, it's a steal because we're getting all of this reading, we're getting a lot more, obviously from our trending perspective, and we don't have to go through that physical stress, and certainly an in-hospital blood sugar curve, for many of us, is more than that. But a lot of us are kind of keeping this thought in mind that if we're doing rental programs, clients can pay the fee to borrow a reader, they replace the sensor as needed, and so this is something where maybe the hospital owns these and rents them out. I think it's a wonderful way to be creative, especially if you have a lot of our clients that want to lead with their heart, but they're strapped financially. So keep it in mind. Okay, I just want a few more minutes. I just want to share a few of the diagnostics that are ahead for us, some of the innovation. So hopefully you're inspired by what we can think about moving forward. Remember, I was talking about biomarkers. This is an inflammatory disease. So a 2024 study looked at this in dogs. They have chronic inflammation. We know that their T helper cells, so CD4 and CD40, are very, very high in these dogs. So they're looking at this as also a potential biomarker, and also looking at some of the immune-mediated subtypes. So not every canine diabetic we're finding, of course, has the same pathophysiology and the same cytokine and chronic inflammatory patterns, so could we get even better at that, those preemptive screenings? Another study was looking at vitamin D metabolism. So we're finding that diabetic dogs have an elevated serum vitamin D as compared to controls. So could we be looking at these peaks of vitamin D early on, similar to what I was talking about with that DGGR lipase? So could we be screening more subclinically before we start actually getting a diagnosis? So this is, again, something where we could be doing a more nutritional strategy to target vitamin D. They don't know exactly the mechanism, but certainly a correlation between significantly elevated serum vitamin D and the diagnosis and development of canine diabetics. And then looking at C-peptide, which is also an autoantibody for at-risk dogs. So C-peptide, just quickly, is an indicator of B cell function or beta cell function in the pancreas, but it's also a biologically active peptide that works around the body, signaling a lot of different things to happen. It's antioxidant, it's anti-apoptotic, so it's anti-cell death. It regulates cell transcription, lots of responsibilities in the body. But essentially, we see C-peptide elevate in a lot of our diabetic complications. So there's a lot more work looking at the role of C-peptide, and that might also be another biomarker. So what does that mean for us? Basically, what we're hoping for are some of these early screening blood biomarkers that can help us more precisely insulin dose, diagnose earlier before these become advanced or complicated, certainly helps us personalize our health so we have a better way of monitoring. Maybe we aren't using CGMs every time. Maybe we're looking at biomarker levels as we look down the line. And certainly it helps us in these combination protocols. So again, looking to make sure that we have that time in range maximized between 100 and 250 for our dogs. I wanted to just leave with just one kind of inspiring story, which I think is awesome. So on the left is a man named Zachary Dickerson, and on the right is one of our colleagues, Dr. Steve Lowry. He's a veterinarian. This is in Michigan. And on October 11th of 2024, Rufus was the first recipient of an insulin pump in dogs. How freaking cool, right? This is the Omnipod. It's an insulin pump. It has 5 computers. It uses AI. It detects blood glucose levels and then administers insulin automatically depending on that level. Love where this is going. So these are being used in teaching hospital right now. There's studies that are working on this. I think this is definitely the future, these closed loop systems. Certainly not out in mainstream GP practice yet, but it's very close. It's very close. So as we think about what human medicine has done, and if you know a human diabetic that is a type 1, they're all on pumps. There's nobody that I know that does not work and live and breathe by their pump. So until that time, we have our CGMs to hold us over, and certainly CGMs for cats as well. We're talking mostly dogs tonight, but CGMs for cats, of course. Could the SGLT2 inhibitors have a role for dogs? I'm sure many of you are familiar, of course, with this oral non-insulin strategies that are available for our non-complicated first-time diabetic cats that are out there. Still experimental, but it's on the way. There's studies that are being looked at to see. And then also non-invasive glucose sensing. So could we have, in humans, they're working on just using your Apple Watch to sense your blood sugar. Really awesome. Working on breath analyzers. Wouldn't it be cool if a dog could just pant and we can tell what their blood sugar is? All of this stuff is not theoretical. It's actually being used in human technology right now. And so we're just waiting because, of course, we're always behind the times a little bit. But we're waiting for it to spill over so that we can have these advancements. But they are absolutely coming. There's all of these sensors. And again, non-invasive glucose monitoring for pets is where we're eventually headed. So I know I went over a lot tonight. I so appreciate your patience, logistically moving rooms. It's so good to see all of you. If you want this deck, that's my email and my 2 sweet lovebirds here as well, Winnie and Samantha. But that's my email at the top. Please just email me. I'm happy to send you everything from tonight. Or if you have any questions, it's getting to be almost 7, and I know you guys probably want to relax or enjoy the rest of your night. So I'll stick around for questions. Also just wanted to say, if you want to look more at the CGMs at a pet team, what's the number of your booth?
11:30.
11:30. So tomorrow in the exhibit hall, if you want to take a look, touch and feel, play around with those CGMs, look at the dashboards. They'd be happy to answer more questions. There's 2 members of the team in the back if you have any technical questions for their CGM, Marcus and Dustin. I'll stay up here if you have any questions. Thank you so much. I hope your first day at Fetch was great. Have a good night.
So, quick question I have for you guys. Do you need a separate reader, or do you have like an app? Okay. Yeah, because like she's talking about like rental and stuff. I'm like, I don't know what she's renting because you don't need the readers. Because I've got a freestyle Libre on my arm right now.
Some of those readers can be up to like $300.
Yeah, like you don't need one though. Most of them have apps, so I just wanted to make sure you guys
No,
had
we use
apps.
that. Yeah.
Okay, and then 9 days?
9 days.
Yeah, 9 days.
Yeah, and then it stores the information for up to 14 days. Yeah, so there's